Now I'd like to present our next speaker. Dr. Scout is the Executive Director of the National LGBT Cancer Network and the Principal Investigator of the CDC-funded LGBTQ tobacco-related cancer disparity network. He spends much of his time providing technical assistance for governmental tobacco and cancer-focusing agencies, expanding their reach and engagement with LGBTQ+ populations. Scout leads a team of specialists who focus on building tools and sharing strategies across state departments of health. He has faculty appointments at both Brown University and Boston University School of Public Health. Scout has a long history in health policy analysis and a particular interest in expanding LGBTQ+ surveillance and research. So please welcome Dr. Scout.
Thank you so much. I appreciate it. Okay, excellent. Then let me kind of start to jump through some of the things I want to talk about today. It's interesting because I feel like some of the issues related to cancer care and equitable cancer care in the queer communities are actually shifting a little bit with some of the different kinds of factors that are going on. So a piece of what I'm going to be talking about is how some of those things are shifting, but what it means and what we're then seeing as far as cutting edge work related to making sure that cancer care is equitable for our populations. I encourage everybody to please put questions in the Q&A box, because without questions, I just get really bored. And so please let's avoid that horror show. Throw lots of questions in to make sure the last 15 minutes are something that's interesting. This is a little bit more about me. You already saw some stuff, so that's not very different. You heard some stuff. If you're not familiar with the National LGBT Cancer Network, just to tell you briefly, we really focus on educating our own communities about our cancer burden, disparities, how to reduce those, advocating within the mainstream cancer communities like cancer support centers to make sure that they're actually reaching our populations, and then also training providers and policymakers and things like that on how to do a better job about being more welcoming. Just so you know, we have a whole bunch of great newsletters that go out. We have a whole bunch of great things on our resource library. We encourage you to visit our homepage to sign up for the newsletters. We are at cancer-network.org. And also, if you're an organization, we encourage you to become free members. All we ask is that you either commit to doing a better job with our communities, and or if you are already doing a good job, committing to sharing some of your information to help bring others along. This is just a couple examples of the kinds of things we have on our online resource library, but we're adding new stuff all the time. If you have outreach materials or anything that's aimed at the queer population, we'd love it if you can share it with us to put this up so that we can, again, help other people not have to reinvent the wheel every time they're doing something. So I mentioned a little bit that idea that there are some changes in the field, which is making this a little bit different. People might be familiar with the fact, I think a lot of people these days are starting to see some of these different pride flags. So I threw some of them up there on top. Some of the pride flags I just see just as examples would be the Philadelphia pride flag, the bi pride flag, the lesbian pride flag, trans, gender non-conforming pride flag, things like that. And so let's talk about a little bit, why do we have such this kind of proliferation of some of these different identity labels and people dialing down into some of these different areas of identification in our communities? Well, first of all, one of the big trends that we've seen recently, and I've been in this field for a long time, and truth be told, this is probably one of the biggest shifts that's ever happened in my adult life. And that's that the number of people who are identifying as queer is changing very rapidly these days, to the point where most recent Gallup poll, which is a full probability study of the US population, says that for the overall population, it's up to 7.1%. But when you look at generational differences, it really starts to get stark there, what's happening, because this is from that same study. We're only looking at adults, but if you notice that top bar there, over 1 out of every 5 of the youngest adults, which are Gen Z, are currently identifying as some type of queer. That's really fascinating and a complete difference from where we've been for quite a long time. just to show you the concept of how that pace of identification is changing, I put together my own little chart, which I enjoy looking at in case the news ever gets me down, that if this rate of change continues at this pace, then you can see that by about the year 2054, something like that, 100% of the population would be queer. And by the year 2060, about 180% of the population will be queer. So as I always like to say, I hope they fix math by then to make sure that that can really be the case. Of course, this isn't, real, but I am noting and pointing out that that rate of change is very stark and something we have not seen. It's not usual business. And so that, I think, brings up a lot of questions about, as people who care about serving this population, does that mean that we're still doing business as usual when the world is not currently at business as usual? Another big trend and change related to this is that of the youngest people who are identifying as queer right now, again, I'm a trans guy. We used to kind of be the unicorns in the queer world, few and far between. You would rarely meet us. We were the least common of anything. That's really shifting. Right now in the queer world, almost 50% of our youth who identify as some type of queer are identifying somewhere on the gender nonconforming, non-binary, or trans end of the spectrum. So that is, again, another huge shift. And for us as providers, or for people who are providers, I'm a researcher, not a provider, that brings up a lot of questions about how well are we tuning our work to these people who may be coming to our door when, for example, if the first thing we ask is, are you a man or woman? If that question doesn't fit these people who are non-binary, how early are we going wrong? And how do we get ourselves back on course? And how do we make sure that all sorts of things in our practice are actually welcoming for this population? And then you can also see there, that little inset down there, that also a huge percent of this gender nonconforming population are reporting discrimination based upon it, and that's as youth. We also know that anything that happens when you're young has a bigger amplified effect on your health throughout your life, so that's particularly challenging. So what does this mean as an upshot? That there is kind of a wave of increasing number of LGBTQI people who are already either talking to us in our practices or will be coming soon. So if we want to do good business and do a good job of actually serving the people to come to our door, again, one size fits all in business as usual is not going to be working for very much longer. For many people, it's already a real failure today. Just some other notes as far as the demographic trends, and again, some of the things are shifting in the population. Another thing that I think is really important to note is that our population is much more racially and ethnically diverse than the general population. You can see here it's almost twice as much. 42% of our population identifies as a racial or ethnic minority. So when we think about this concept of intersectionality and making sure that when we tailor materials, tailor resources, tailor behaviors, things like that to different populations, it's really not optional in the queer communities. You need to start from that basic lens if you're going to do a good job of serving us. So another thing that really, you would think that politics and health don't necessarily interact a huge amount. Well, maybe we do think they interact a huge amount these days, but there is one aspect of this that really is affecting our population, and we're carrying that stress, that strain, and those increased health risk behaviors and things like that we use as coping skills into health providers' offices. And that's that every single year, every single legislative session, we are now setting new records for the number of anti-queer bills that are being introduced on a statewide level. So, in California, there is full LGBTQ civil rights, non-discrimination protections, but that still doesn't mean that we can't have some of these other kind of bills be introduced. And unfortunately, each of our states are not an island. So when you are seeing queers who come to your door, we are seeing this news about this historic level of anti-queer legislation being introduced all around the country. And then, unfortunately, we see how that also affects, in many cases, our mistrust of the medical system. This is an example from the great state of Florida. We were really happy that the Florida Department of Health tobacco control section started to reach out. And as you can see there, they are one of the sponsors of one of the Pride festivals in Palm Beach the other year. just last year, actually. But the problem is, this year, that same Florida State Department of Health, supporting one of those anti-trans legislative bills, decided to put out a position statement saying that health affirming care for trans youth was actually not medically indicated and was harmful. Of course, they skipped places like the American Academies of Pediatrics and the American Medical Association and the American Psychiatric Association as their references. They instead went to places that I didn't even know exist, like the Catholic Medical Association. But the state of their science aside, the important thing is we now see a whole state taking a stand saying that what we understand from research is life-affirming healthcare, which can drastically reduce suicidality rates and things like that for members in our population, is bad and should absolutely be banned. And again, whenever we're talking youth, it has a bigger effect on our full life course. So these are the kinds of headlines that we're seeing whenever we read anything about queer news anywhere in the country. So even if we're in a state that protects it, unfortunately, this is the wallpaper of the world that we're living in right now. And many times it means that we also are more mistrustful of providers. We know that these things have direct effects on our mental health. And one of the things, long ago, we saw research showing that before there was even this kind of wave of anti-queer legislation, if there was one anti-queer law that was introduced in a state, they actually were able to measure that the mental health of the people, not just in that state, got worse, but the people in the states around it also got worse. So if that was the case when we used to have one bill introduced every so often, what does that mean when we now have basically wallpapering of these bills end to end in our country? We know that it affects youth mental health. We also know that there's the number of youth that are talking about how it affects their mental health. And just to be clear, when we're talking about this population, for example, trans people, usually on average, over 40% of us have attempted to commit suicide at some point in our life. Imagine being part of a group, if you're not already trans, where every time you see any two other people who are part of your group, one of you has tried to unalive yourself because of that incredible stress of the negative stigma from the general population that you see. And so, just as an example, these are the scars from one of my many suicide attempts. So we live in a world where we have a lot of people who are really struggling as mental health effects with some of these societal expectations and the burden of the discrimination. But you also see, here we have a youth survey that came out pretty recently where the incredible percent of these youth talking about how these new laws are really affecting specifically their mental health, including 85% saying it's affecting it negatively among the trans population. We also know that non-discrimination laws increase and improve our physical, economic, and mental well-being. So just as an example, again, this is a survey that was done talking about what discrimination, what kind of effects that has on our mental health, things like that. And it also talks about the number of people who experience discrimination in different kinds of scenarios. And if you can see that second thing down there, you see that for following or at a doctor's appointment, you can see that the percent of LGBTQ folks who experience discrimination, including that there was bias, including that it was they were blamed for health problems, they were denied or refused care, in each one of those scenarios is much, much higher than the non-queer population. So a lot of what we walk into, let's put it this way, if you're not talking with a queer person themselves who's directly experienced it, it's almost impossible for that person not to have someone in their immediate group of friends who has experienced it. And associative trauma is big for any population. In our population, this is very salient. So even if you might say, oh, something, we protect LGBTQ men, we protect LGBTQ health in California, and our practice is welcoming, what I need to convey here is you're still dealing with a population that comes to you traumatized in the first place. And so that, I think, brings up some good questions, is what do we do to counter that and show that we're not going to be an ongoing part of that trauma when they walk into our practice. So just to give kind of a little bit more of some of this, what world we are living in before we walk to your door, another thing we also see is that this was the other year, this was a really exciting thing because we were tactically closer to getting nationwide non-discrimination protections than at any point in my life that same year. And it was really cool to see this big, summit happen on Capitol Hill about potentially passing nationwide non-discrimination protections. But just because we bring everything back to cancer, look at one of those three sponsors is Philip Morris International. So we love this idea that, we're making great strides on some ends, and then cancer comes riding right in on the coattails. And unfortunately, that's a piece of what you'll see as far as kind of our bigger factors that we have related to cancer. Another thing that I just think is a shifting trend in our population right now, these are all pictures from the Cancer Moonshot launch event. And it just really strikes me that, with, Dr. Biden, with President Biden, with Kamala Harris and her husband, sorry, oops, that was a little Freudian slip, her husband as well. We've got more people who are directly impacted by cancer in the executive branch right now than I can ever remember. So that shows, I think, great potential promise for what we might do as a nation to reprioritize cancer and address some of these risk factors which really can be changed. All right. So the next thing I just want to kind of go over briefly is, so what are some of those reasons why we're more likely to go see oncologists, unfortunately, than the general population is? And if people aren't familiar with this little random school supply picture up here, the reason why this picture is kind of notorious is because practically half those items up there are e-cigarettes, all made and designed to look like school supplies so that parents don't know that their kids are using e-cigarettes. So we know, actually, we have a long history. We know more about its history in California than in many other places of the tobacco industry specifically marketing to us. Take pride in your flavor. We saw a lot of this actually happen. It started in the 90s. And like I said, California is one of the places where we knew the most about it, including the tobacco industry reaching out and buying huge amounts of ads in our media, specifically saying, they would ask our own advisors, what's a good message we can give the queer communities so that they don't vote against, in that case, it was a smoking ban, right? Or a smoking tax, I think it was. There's been these kind of bills that come up a lot, whether the tobacco industry wants to sell something that, is cancer causing, and what does their general population think about it? And what our advisors said, you got to come up with messaging that builds off of our existing civil rights battles. Like, for example, whenever someone says, dude, that's so gay, we'll be there. That is actually a quote from a Lucky Strike ad. Or there was another one that said, freedom to live, to love, to breathe, to inhale, it's all good. So, that whole message is great, except for the to inhale, except for the smoking freedom message they kind of snuck in there, again, on the coattails of our civil rights battles. So the tobacco industry is really clued in to the challenges that our community is facing. And, the real question is, how long is it going to take for the health industry and the healthcare industry to also be as tuned in to the kind of particular messaging that we need? This is just some more examples of more recent sponsorship that we see going on in a lot of pride parades and things like that from the tobacco industry. Oops, that one is a repeat. So we've created some resources to try and counter some of these things and hopefully educate more of the queer communities about this connection. This is just one little one I will play for you.
Hello, my name is Spike. I'm a queer Latinx multimedia artist and performer. I am 34 years old and a native Angelino. I started smoking at a very young age. I was 12 years old. I stole my first cigarette from my father. It was a cool menthol. I started smoking because everyone around me smoked. Everyone I looked up to smoked. I was a premature child, so I was born preemie with underdeveloped lungs. I developed asthma. I'm now on 2 breathing inhalers and 3 pills that I take daily for my breathing and my asthma. That is due to smoking for an extended period of time. I'm more out of breath. I can't dance as long. I can't perform as long. Smoking tobacco does have long-lasting effects, and I'm here to tell you that. So that is my story. That is my view. That is what's happened to me. So I hope I can shed some light on that for you today. Thank you very much. Hello, my name is Spike.
Keep going. Thank you, Spike. We appreciate that. So that's an example of the kind of things we do, because unfortunately our communities don't even understand we have this big smoking disparity compared to the general population. Here's some other examples of the kind of promotion that we do, again, to try and help our communities understand that we use menthol at higher rates. We use the flavors at higher rates. we obviously use cigarettes at higher rates. And in most cases, we don't even realize it's a health disparity. So that's, tobacco is kind of the biggest precursor there is, obviously, to cancer itself. So now let's look at cancer specifically. Some of the stuff I'm going to be bringing up now is from the survey that we conducted about 1.5 years ago, which is the biggest known survey related to queer cancer survivors. We had about 2,700 respondents. Just to give you a sense of the kind of stories that people talked about when they got into care or were trying to get into care.
Throughout sessions 1 and 2, we've learned the importance of listening to LGBTQ+ people, asking questions, and not assuming you know all the answers. Assumptions can be extremely dangerous. Listen to this story from one of the surveyed patients.
My primary care physician was aware of my symptoms 4 years prior to discovery of anal cancer. She detected blood during a prostate exam and gave me a prescription for medicated suppositories. The bleeding went on, but would lessen with suppositories. It wasn't until my husband made me go in that we discovered my tumor was the size of a golf ball. I asked my doctor when I was done with treatment, why didn't she send me in earlier for a colonoscopy? She said she thought the bleeding was from gay sex. We had never even discussed anything like that prior at any time.
And now in kind of a similar story, let's hear from one of our other survivors talk about the same common challenges related to even getting diagnosed and getting heard from your provider.
So I've been living with HIV for a number of years. And you would think that the one place that a gay person would be affirmed and really cared for was at the HIV clinic. Well, that didn't happen. It actually took them about 9 months to diagnose my cancer from my first initial complaints about having pain on my backside. I got all types of reasons for them not seeing me. Well, come back to your next appointment in 6 months and take these pain pills. So I dealt with that for probably about almost 9 months before I finally got a nurse practitioner who, after I told about my issues, called me in and did a rectal exam. Now, if I'm complaining about what I think is an internal hemorrhoid and you're treating me for 9 months, like somebody should have done a rectal exam by now. I've literally had more action on the first date. So
Tony is always amusing, definitely. But unfortunately, this is a theme we found, and one of the challenges was not only getting providers to acknowledge people, but also it was really hard to find some indication that a provider was welcoming. So, I just talked to you. I had a bunch of information about how hostile the world can be for us right now. Yet, despite that, only 12% of people who are going to get cancer treatment were able to find any indication that the provider was particularly welcome to queer people. And then a lot of them talked about this idea that they had to go through a lot of steps in order to find a welcoming provider in the first place. These were some of the interesting strategies that people used. And you can also see that, sadly, even the NCI designated cancer centers, what we might think of as best in the world, only 47% of them, only a little over half of them have any findable queer non-discrimination statements on their website. So in absence of that, these were some of the interesting strategies that people used. Sorry, I meant to go back to that. In order to figure out, is it going to be safe for me to get cancer care at your office? We also see, other kinds of things. So I'm a trans guy. If I see this and yet I need to get treated for uterine cancer or something like that, this is where I'm left with going. And this is, of course, at one of the world-class cancer institutes. On the other hand, sometimes we see better things happen. Sometimes this is during Pride Month only, but hopefully it's all throughout the year. We actually did a big analysis of NCI designated cancer centers this last Pride Month. And it was really interesting how many cool things we found, like, when they light up their whole tower in queer flag colors, that's kind of great. But the sad part is that like 35% of them, we found absolutely zero on their website or even during Pride Month. So again, let's get a sense of how treatment goes.
Fear of discrimination is a real and reasonable concern for many of us, especially among our transgender, gender nonconforming, and racially diverse community members. Discrimination can negatively impact our cancer diagnosis and treatment experience. One of the surveyed patients shares her story.
I was first diagnosed with cancer at age 17. My care was great and respectful. I developed cancer again at age 27. I noticed a significant shift. My doctors were dismissive. They often delayed or deprioritized testing and failed to inform me about various treatment options. And when confronted, they were hostile and immediately dismissed my questions and research. I was made to feel it was your fault, probably from such a reckless lifestyle. I lost my shit. They repeatedly insinuated that I used crystal meth and other party drugs, despite being a teetotaling cat lady. I have repeatedly encountered oncologists, radiation techs, nurses, and primary care doctors who are impatient, seem offended, or are openly hostile to me when I'm alone at appointments. When my brother, father, or husband attends with me, it is a completely different tune. They immediately act surprised that a trans woman has a husband, dad, or brother who cares for them. All in all, cancer treatment has been the absolute worst setting for hostility, transphobia, outright aggression, and violence. I have several times had my genitals examined, fondled, or catheters inserted without my consent. And when filing complaints with hospitals, been dismissed outright, despite many of these instances being unnecessary or prurient to satisfy the curiosity of the doctors.
Sadly, this is also
Fear of discrimination.
Sorry, it always does that. This is also a real theme we experience. I'm gonna show Dana's too as another way to talk about how being trans and having cancer care is sometimes a bad interaction as well.
So in 2015, I was in the process of scheduling surgery, top surgery, to begin transitioning. And in May of 2015, I doubled over in pain, and it turned out I was dealing with cancer again. I'd had a reoccurrence. I started talking to my primary care provider in 2016 about the possibility of taking testosterone to continue with the transition process. So he got back to me a while after I initially asked him to do this, and said that in talking with the endocrinologist and my oncologist, I was a little surprised about that they decided that it was best that I not take hormones, because they didn't have enough research or information to know the impact of testosterone on the kind of cancer that I have. I'm now in a place where that's stabilized, and because I'm taking medication that seems to be working. So I'm grateful that I'm in a stable place in terms of my health regarding cancer, but at the same time, I continue to be very sad and disappointed that I can't continue with this transition.
Sometimes our challenges are not even necessarily with the providers, but the fact that there's not enough of a base. Because, for example, if you're not collecting sexual orientation, gender identity, and intersex data on an electronic health record, then you're part of the reason why we're not in cancer registries, because that's where those data come from. And because we're not in cancer registries, researchers have a hard time even justifying to NIH, a very competitive funding environment, doing the kind of research that will get answers to those questions. You can also see some of the other quotes we haven't put into animations here of some of the thematic issues we found. An idea that we wouldn't care about fertility preservation as we went into cancer treatment. This is one of the ones that always makes us laugh. But this idea that also that providers wouldn't necessarily know about sex after cancer for us. We also see this a lot with anybody who has anal sex. if you've got prostate cancer, then you're asking, what's that going to be like for sex after? And anal sex is not the same as vaginal sex, but many providers just like, I have no clue. And this is a sneak peek at what is coming from our forthcoming analysis, our multivariate analysis of that survey. And the thing that I like about this is this really shows us something that we can change, basically. So what we found out was the people who rated their providers very welcoming were almost 7 times as likely to report being very satisfied with cancer care. And again, the great thing about this for us is you can become very welcoming pretty easily. It doesn't require a lot of changes. So if you're looking at doing a better job of creating positive patient outcomes and stabilizing the mental health of this population, addressing that, how welcoming your office is a critical variable. And nicely, again, it doesn't require big changes to do it. We're going to go through some real strategies in a couple seconds. Oh, no, sorry, by that I meant right now. So the strategies here, I'm going to go through, I think, 8 of them or something like that. And some of them are kind of organizationally based, some of them are individually based. So there's kind of a melange for, wherever you might be as far as being in the cancer world. But just to go through each of them, the first thing is I'll give you an example of someone who's done it. Spitfire Strategies, they are absolutely great. We love them. It's a communications firm because what they do is one of the most powerful things that can happen these days right now. And that's they ask all their staff team to put their pronouns on their emails, on their Zoom, and to introduce themselves with their pronouns. Understand, if you're not familiar with pronouns, it does not mean you're queer. It simply means that you understand that a segment of the population that you care about has experienced profound discrimination, stress, and unrest because people have presumed to know pronouns and misgender us. I spent most of my life being misgendered. It is not pleasant. And so when you put your pronouns out there, what you're saying is, I understand this is a huge problem for some people. I don't want to be part of that. And you open the door to other people telling you what their pronouns are, especially if their pronouns may not be the ones you presume by looking at them. Next up, we're going to give some praise to UCSF. Actually, that is this poster over to the right here. What kind of flags of welcoming are you putting in your physical locations? So this is this UCSF poster. You've seen versions of this in a lot of places. The one thing I'll say about this is I think it's sad that I'm more likely to see a poster like this in my bakery than I am in my health provider's office. And what does that say? That somehow my bakery is more interested in making sure I have a welcoming environment to buy a croissant than my healthcare provider, where I'm going to get naked and spread my legs or something like that. So this is a place where we have a lot of improvement to go. Next, American College of Radiologists, really excited by that because they have decided to launch a whole campaign where they create a bunch of tailored resources, both for people who are coming to a radiologist's office, for the people who have to go, and it's such a key area related to cancer screening and evaluation, of course, but then also for their radiologists to make sure that they're doing a good job with the population. And then Moffitt, we love that they are doing such a good job at, and they're one of the cancer centers, they happen to be in Florida, of queer data collection. As I said, if we don't get data collection into EHRs, it'll never get into the cancer registries, permanently kind of binding our hands as far as being able to get the research and interventions we need to change our health disparities in this area. Okay, 4 more power moves. What's NAACP doing right now? You may have heard that FDA is looking at banning menthol, and we hope at some point they might consider banning all flavors, particularly these e-cigarettes. But speaking up related to that is really, really important. And don't be swayed by some of the noise that the tobacco industry is buying to put into the equation. Whenever anybody is looking at banning flavors, they're never looking at having any consequences for a user. They're only looking at stopping the access pipeline. So again, the tobacco industry would like to, they're sadly, funding like George Floyd's relatives to say it's going to cause more violence against Black people, but that's noise they're adding into the equation. That is not actually the consideration of places like NAACP that really care about these issues. All right, what's Sinai Health doing? They're not just collecting data with the population, making sure they're welcoming of the population. They're also doing additional research with the queer patient population. Despite being hugely welcoming, they found out that the trans people in their patient community were 40, 50, and 60% less likely than their other patients to get I forget the exact order, but it was breast, cervical, and colorectal cancer screenings. And they realized they had a problem with reminding for some of those screenings for some of the people, but obviously everybody has a colon. So it speaks back to this idea that we also need to make sure that when we hand someone to a referral, that we do maybe what Cal and Lord does in New York, a big queer FQHC, they as a provider call the person they're referring to make sure they're going to be welcoming to the queer person they refer to them. And then they check back in with the patient to make sure it's happened. So whenever you've got that referral and we have to face finding another provider that we may be getting naked in front of and being very vulnerable in front of, it means we've got 1,000,001 reasons to put it off. I speak from personal experience there. So what's HHS doing, Health and Human Services? They have a sexual and gender minority health task force. If you're a big health organization, you should absolutely have this. You do a lot of DEI work, we should absolutely be woven right into all that DEI fabric. What is Cleveland Clinic doing as one of their power moves right now? They have even created an office of LGBT health in that cancer center. So all of these are ideas that you can take back to do a better job with the population. You know, we talked a little bit about pronouns and the number of people who are non-binary, things like that these days. So I'm going to, just a second. Yeah, I'm going to take just a second and play one of these videos so you can get a little bit of a sense of how to use some of the unexpected pronouns. Nope, not that one, this one.
Have you met my friend Alex? They're going to be at the party tonight. No, I don't think I've met him yet. Oh, Alex isn't a guy. Alex is non-binary. They use they, them pronouns. Like they, them, theirs? I'm not familiar with using those pronouns. What if I mess it up? Oh, thanks for telling me that. Do you want to practice before we go? You won't judge me for getting it wrong? No way. I practice all the time. Here, I'll give you some examples of how I would use Alex's pronouns, and then you can try. My friend's name is Alex, and they use they, them, theirs pronouns. They go to school with me. Their partner's name is Sarah. Alex loves dogs. Their favorite breed is a German Shepherd. I'm nervous. Okay, why don't you try using Alex's first name, their proper noun, and then we'll move on to their pronouns. Okay. Alex seems really cool. Alex goes to school with you. Alex is going to be at the party tonight, and I'm really excited to meet Alex. Great job. Now practice filling their first name in with their pronouns, they, them, theirs. Okay. They're going to be at the party tonight. I'm excited to meet them. I think they're going to be really cool, and I hope they like me. Great job. I think they really are going to like you. Okay, but what happens if I mess it up? Here, I'll show you what a mess up might look like, and then you correct me, and I'll show you how I would respond. Oh, look, there's my friend Alex. I like his shoes. Their shoes. Oh, you're right, I'm sorry. I like their shoes. Thank you. So I would apologize, correct myself, and thank them for correcting me. Yep, and then you try not to do it again, and you practice whenever you can.
So it's a great, minute and a half kind of summary of how to do some of those things, which I know are maybe confusing a lot of us. I really would encourage people to practice, and sometimes practice by having imaginary conversations until you get a little bit more easy with the idea of using a pronoun that may be unexpected. All right, so the last thing I want to close with before we're going to get to all these questions, which I'm sure you're putting somewhere. Oh, I only see one question in Q&A. Oh, that's terribly disappointing to me. All right, you're going to give me more, right? Please just do that one thing. Is that I'm going to throw out some resources. We've been creating a whole bunch of new things. We're doing our best to madly offer more resources that we give away to free. And if you are a member, you can also put your own logo on these resources. Remember, as I told you earlier, membership is absolutely free. So I encourage you, become a member, but please use these resources, because imagine us, we're like a place that sells gardening tools, but we have no land. If you actually see people who have cancer and who might be queer, you're the ones who have the gardens. So we want you to please use the tools. Okay, the first thing is we have this great website that helps educate our own communities about the fact that we have a tobacco disparity, how that is connected to cancer, and what kind of resources are out there that we can use in order to try and go through cessation attempts. This does not teach anybody how to quit smoking, because we understand there's a lot of customized, tailored, high-end cessation resources out there. It just takes us and gives us a tailored front option to look at some of the things that have particularly affected our community so we're more educated, and then encourages us to go out and use other cessation resources. Next, we're really happy that last year we debuted the first that we know of right now, at least in the country, page related to being trans and having cancer. So that is on our website, and you can link to it on your website, on your information page, follow up, everything like that. Third, we are super happy that we've been running for about 1.5 years now. These virtual support groups, they're the first we know of in the country that are for any kind of queer person with cancer. They happen currently 3 times a week. They are absolutely free. But again, no one will know about them unless places like you actually promote the fact that they exist. So what you see here is a flyer. And again, if you're a member, you can also put your own logo on this flyer, or you can redo it, but please tell people that these free support groups are out there. Many people talked about needing them and wanting them. We talked a few different times about how there's this idea that providers don't even understand what sex after cancer is like for our population. So we made a page about that too. We made a microsite about that too. And again, this is something you can provide people in their survivorship care plans. This is something you can look at and learn more about yourself. This is actually Daniel Garza, one of our dear friends who is in LA. As a matter of fact, he is LA based, and really an amazingly brutally honest, forthright, and hilarious survivor who does a great job of kind of really breaking it down. His story is on there among a bunch of others. And then you saw in some of those videos, the cartoon videos, that it said, you know, you've gone through part 1 of blankety blank. Why was it saying that when it was the only video I showed you? It's because they're all excerpts from this big training program. So if this hour is kind of teasing you to maybe learn more about the population, then the next step is absolutely dive into this. It is, you can take up to 5 parts for anybody who's in cancer, the first 5 main modules. If you're specifically in trans gynonc care, there's 3 extra modules just for you. But the first 5 are really for anybody in the health world, honestly, who is serving queer people, to give you more in-depth orientation about how to do a good job serving our population. It's completely free, full CEs. It will be free through the end of this year, and you can reach it at that website right there. And then I also just want to say we have a new thing coming. It has already come because July 2022 was passed, and that's our Cancer Leaders Like Us program, or CLUE for short. And this is focused on supporting early career people who are either BIPOC and or queer who might be interested in going into the cancer arena. Because of course, if we want to see a set of cancer providers as diverse as our population, we're going to have to nurture people from a younger point in their career. And this is our attempt to do that. So if you know anybody who falls into any one of these categories, please have them get on there's a sign in our website. Again, that's cancer-network.org, as you see right there. There's a little sign in if you want to be on our mailing list, and it asks if you're one of the people who might want to especially get information about this program. We also have a brand new colorectal cancer toolkit. So this has resources for people who are interested in looking at their risk factor all the way through to treatment. Please check it out on our website. These are some, we also have like cards, things like that, educational cards you can put in your office, especially if you're trying to make your office materials be more queer welcoming. It's a great option. And with that, we are on to question and answer time. How did I do my time? Oh, yes, I'm really close. And if you are a fan, we encourage you to please leave a review actually at a great nonprofits. If you think that this has been educational or helpful for you, that would be super lovely for us. And I think that scan code gets you there. And then with that, I think the next thing is thank you from us, and we are moving over to the Q&A section. I'm gonna stop sharing my screen.
Okay, thank you so much. That was a wonderful talk, Dr. Scout. Really appreciate you adding that last mentorship piece, right? Because we do need an increased research focus on sexual and gender minorities. And, you know, I'm glad that there's now an office for sexual and gender minority research, but we don't have enough researchers that are from the community, right? The whole idea of nothing about us without us. And so I love
not
that
at the table, you're on the menu.
Exactly. So I'm going to be sharing that. And so we have some questions for you in the chat. And so the first question is, first of all, it's a compliment, amazing talk. And they're saying, I'm curious about what comes first, the messaging or the practices. I would love to have all our staff at our organization put pronouns in their signatures, etc. Tried this with limited success. put up a sign like the UCSD, but I'm worried that our internal practices don't necessarily create the safe space for our participant population. Does it need to be top down?
Well, it's a great question. I think what I see a lot of practices doing in reality is they will send their staff to a training, then they do not follow that up with public facing activities. So if you sent your staff to a training and you have your expectation that your staff are actually going to be welcoming, but you're not checking whether it's patient satisfaction surveys or whether it's that you have, we all have, if there's a grievance, that kind of stuff, that information is out there in a lot of our offices, stuff like that. But if you don't have non-discrimination signs in your office, then how are we supposed to know that there's any of that welcome out there in the first place? So I feel like when you just go to a training and you don't follow it up with something like that gets out to the patients and is also an expectation of the staff, that's apparently the right person didn't go to that training because you're failing there. But as far as which one of those two things is first, I'm not sure we have a lot of evidence as far as which one is better to go first. But I have to admit myself, I think when you set a public expectation in the public areas of your website, your physical offices, and then you also offer people the opportunity to complain if things are going wrong, and you are conveying loudly to your staff, we expect you to do a good job with this. And I'm not saying you would ever do that without also giving your staff the actual resources like access to welcoming spaces or things like that and time to take it. But I do feel like that public conveyance of welcome shows your staff that there is a standard you're holding them to, as long as those people have a clear grievance option. If it doesn't meet that, my suspicion is that is probably one of the fastest ways to create a different environment at your organization.
Wonderful. Thank you so much. We have another comment from a participant that says, this training is amazing. Thank you so much. So
I'll quote them on that. How's that? Thank you very much.
Yes. And our next question is, how would you recommend disseminating these resources you shared?
I think then we got to think about what are the ways that people, that the patients that we get near get any of their resources. Of course, sometimes they're going to get it just by Googling, right? But on the other hand, we do things like we do survivorship care plans. When we're doing that, do we have tailored resources and survivorship care plans? When we see people who are coming to us at the very beginning, like if you're seeing a queer person with colorectal cancer, do you know that there's a tailored resource you can talk to them about so they can learn a little bit more about this? So sometimes we're telling people individual resources. Sometimes we're specifically putting it into something like a survivorship care plan. Sometimes it's that we're putting things on our walls. So I think in that question or in that situation, I would really kind of think of, in your scenario, how is anybody figuring out information? If they're only figuring it out because the providers are telling them, then make sure the providers know about these. And I would also encourage them to make sure they also have tailored resources for all the overlapping underserved populations. Black folks, Latinx folks, everything like that. If we are part of a population that has experienced systemic disparities, then we as health providers should care about trying to do something to offset those disparities, and tailored resources are a key piece of that path. So make sure your providers have the information, or if you put it up on the wall, make sure it's up on the wall, or if in survivorship, make sure it's there. So how do you get them information now?
Yeah. Thank you so much. And having it created by people who are from the community, right? So that it's reflective of them.
Right, which again is why we let you co-brand things, because that way our stuff is on it and they can see that like Queers created it, and whatever organization you're part of is also a piece of it, which helps take some of our credibility with the community and transfer it to you as well.
Yeah, thank you so much. And I'm going to sprinkle in another compliment here. This one says, thank you for your valuable presentation and your ability to make it entertaining. And I completely agree. So our next question is, what are the ways that mental health practitioners can get better at addressing unique psychosocial effects of cancer on LGBTQ plus in treatment?
Oh, that's a great question. And actually, I wish I would have started to speak about this a little bit more. So it's really common in our world. We know from like sociology that we create social support from what's considered 5 domains: where you live, your home, your neighborhood, your work, your family of birth, and your friends, right, are the 5 general domains of social support. Now, as you can understand, for a lot of queers, we may have zero social support in several of those domains. It may not be welcoming at work. Our family of birth may not be welcoming. So we're over-reliant on some of the other domains. And what we do see related to people who are going into cancer care is that we are more likely to construct our support groups, let's just say ingeniously, right? So you may be more likely to have someone come in and the person that's the primary support person is an ex and the new partner of the ex kind of thing, because that person may not have as much family support as a lot of the rest of the population has. So first of all, we have to understand that our social support paradigms we do not have as much as the general population. And that for us can create an added burden of isolation throughout the cancer care process. And anybody who's familiar with the cancer care process knows that that alone is incredibly traumatizing for people, right? So you should expect that we have that incredible added burden. And you should be thinking about, if you're dealing with someone who's going through cancer, what can you do as a mental health provider to help them reassess some of the social support routes open to them? Like, for example, if they're an older person, SAGE is the elder organization, and they have a mental health support line that you can call at any time. Very few people do, because it's hard for us to ask for help, right? But many of us need more of it than we realize. Or you refer them to these cancer support groups that we have. Truth be told, there's about 100,000 queers, according to demographics, that should be being diagnosed with cancer every year at least. And those support groups still have plenty of availability. So that means that people aren't even understanding that some of these resources are there. So you should expect less social support, all the sequelae of what happens when you go through a traumatizing life event with less social support. And how can you as a mental health provider then be as ingenious as we have to be with creating our families in creating more structures and more assistance for us in that environment?
Wonderful, thank you. And we know that those numbers are underreported, right? Because as you were saying, we're not collecting the data. So
right.
Even those, those estimates we know are underreported. Now, Our next question, and you brought up support groups, and they're asking, can you speak more about the support groups offered for people who may be nervous or resistant to joining?
Yeah, so that's a great thing. I think that people are often kind of like, I don't know, I don't want to put myself out there. And some of us are like, please, not another Zoom call. But that said, it's really just a place where you can go and talk about any aspect related to your life. It doesn't even have to be cancer, right? Because it is for survivors of cancer. You do not have to be in treatment right now. I mean, I know people who are really struggling with their survivorship from cancer 20 years after their treatment ended. And they are seriously trying to stabilize themselves. So you do not have to be in treatment right now. You do not have to, you can be long after treatment, or you can be right in the thick of it. But it's a place to come and talk to other people who've experienced cancer who are in the queer communities. It's a place to just bring up anything that's stressing you. It is a safe space where if you want to talk about anal sex, or if you want to talk about, what it's like not to have breasts when breasts were not a big part of your sex life, whatever the thing is, being queer is just the wallpaper in the room that you don't really see anymore because it's a given. And so everybody there is listening and supporting each other. And we've got the people who've been involved with them have been so overwhelmingly positive. And actually they're run by someone who's right out in your part of the world too, as a matter of fact. So it's just basically a free space. If you're trying to deal with the stress in your life and you have cancer, come talk, no expectations. You can be quiet and listen. You can only speak up when you want to.
That's great. And again, another compliment, they said just in all caps, so they're yelling this, fantastic, thanks. Just so you know, that's how great it was.
Y'all are too sweet.
Well, I agree with them, but yeah. So another question here is there a checklist that you've developed that helps organizations determine how welcoming to the LGBT community they are?
It's actually one of the things we've been writing some proposals around, trying to create a toolkit related that for offices recently. So we don't really, we actually, I should say this, we do have an old one that we had created a while ago under a different project. So we could probably pull that back out. I don't think it's well prioritized on our current website, but I could probably pull that out and send it off to the people who are participating in this if you're interested to see it. Yes, absolutely.
That'd be wonderful. Thank you so much for sharing that. And then our last question is, where can we find the tools you recommended?
Okay, so I think everything I talked about is all on our website, cancer-network.org. And you'll see, if you're an individual who wants to get more information, at the top right, it's like, sign up information. And if you want to get more information on a mentorship program, anything like that, it's there. If you know survivors, whenever you get close to the website, there's actually going to be a pop-up on the whole website saying, are you a survivor? Interested in more information? You can sign up there. Or if you're an organization who wants to get that free membership and co-brand things, then at the bottom, there's a become a member part. So any one of those three things you can do. Again, we push out a lot of these tools on our monthly newsletters, and we have a whole bunch of stuff on our resource library. But we have all these microsites that I talked about built in to the actual website, and including welcoming spaces, which is that big state-of-the-art training, which is free at least through the end of this year for anybody who wants to learn a lot more.
Well, thank you so much, Dr. Scout, for shining a light on the very special needs of the LGBTQ community when it comes to cancer care. And thank you for also inviting us, if we have developed materials for the population, to share them with you. You're absolutely right. No need to reinvent the wheel. So I'm hoping maybe some of our attendees have done some of this work and can be able to share it, so that way it gets, there's a broader reach and dissemination, because there's always a huge need. So thank you all, everybody, for joining us. And hopefully you visit the LGBT Cancer Network website to get some of these tools and resources. And for now, we will take our lunch break, and we will be back at 1 p.m. So see you all at 1 p.m.